So welcome to this final crash course session on oncology, taught by Dr. Nazifa Allah. If you look on the top right hand side, that's the link to our Instagram page. So please do follow us, and then you'll get all the links to all the upcoming sessions. And on the bottom left is just our email address. So please email us if you have any questions about today or anything about sessions in future, then give us an email and we will get back to you as soon as possible. And then on the next slide, this is the link to the polls for today. I'll post it in the chat as well, just in case anyone joins late. But please do log in, and it's completely anonymous. So all we see is the number of people who voted for what. So don't be put off if you don't know the answer. Sometimes it's actually really useful for us to just know that you don't know the answer. So just have a guess. And yeah, I'll hand over to Nazifa.
Cool. Okay, evening, guys. So today I'm going to be doing a teaching session on oncology. Now, oncology is a very, very broad subject, and it's quite a specialist topic as well. And so whilst I was at med school, particularly for finals, the main thing when it comes to oncology is that you need to know the stuff that you would be expected to know as an F1. So for this teaching session, I'm not going to be going into the details of different types of cancers, because that would take us ages, and also every single part of your body could be affected by cancer, so that would just not be the right thing to do. And you don't really need to know you don't really need to know the ins and outs of detailed management for cancers, because like I said, it's quite a specialist topic in general. But what I will be going over is I'll be talking through some of the fundamentals of oncology. So I'll be talking about screening programs. I'll be talking about the generic ideas around staging and grading, and some general principles around management that is useful to know. And I'll be discussing something called performance status. And this helps us kind of guide the kind of management that we will do for someone who is affected by a certain type of cancer. I'll also be going through the scenario where you may come across an individual, say, for example, in A&E, who may be presenting for the first time with a cancer, and we don't know where the primary origin was of the cancer. And of course, I'll be talking through oncological emergencies, because that's very important for you guys to know, particularly in your junior years, and also some red flags and referral pathways that, particularly in the GP setting, it's important to know. But as I mentioned, I won't be covering all cancers, because that would be silly thing to do and we would be here for hours. I won't be covering hematological malignancies, because I believe there is another teaching session that will be done or has already been done looking at hematological malignancies and hematology in general. And I also
at the end of the month, I think, or possibly start.
Okay, cool. Cool. So that's going to come up. And I believe we've already had a session on palliative care. So I'm not going to be going through palliative care prescribing and things like that, because that's already been done. So look at the YouTube channel and things like that if you've missed it. And also, please do tell me, guys, if I'm going through too fast or you want me to explain things, just pop a message on the chat and I'll slow down or try and answer any of the questions that you guys have along the way. So without further ado, one of the first things I wanted to discuss when talking about some of the fundamental principles behind oncology was, of course, screening programs. And there are three main screening programs that you need to be aware of. Just to let you know, with screening programs in general, they're a type of secondary prevention. So they detect early stages of diseases before you have sort of the full symptoms develop. So it's it is categorized as secondary prevention in terms of the type of treatment that it is. And the thing with screening programs, when you decide whether a particular disease should have a screening program, you need to look at, number one, the prevalence of the disease, whether there's enough of that in the sort of community to warrant a screening program, whether there's a high mortality, morbidity associated with that disease that you are trying to do a screening program for, whether there is a potential intervention or treatment plan or treatment sort of available for that disease of which you're trying to put through a screening program, and whether, of course, it's cost effective and acceptable to the public. The reason I bring that up is that sometimes, particularly, I've been asked before in OSCE scenarios, what's the utility behind screening programs and why would you want to do a screening program? And so those are some of the points that you can mention. But in general, a big screening program we have is, of course, the cervical screening program. And the main aim is to detect sort of pre-malignant stages to cervical cancer. And what you do is you do a smear test, and it's offered to those between 25 and 49 every 3 years, and for those between 50 and 64 every 5 years. And if you're pregnant, you do need to wait until at least 12 weeks or 3 months postpartum before you do the cervical smear, because if you're pregnant while doing the cervical smear, it gives you unreliable results, basically. So you need to wait at least 12 weeks postpartum to have your routine smear test. And if you are HIV positive, or you've previously tested for cervical cancer, particularly stage 2 or 3, then you need to go for annual screening tests for cervical cancer. Now, in terms of what happens behind the actual screening program, PassMed have a really nice description of how the screening program goes. So I would definitely recommend looking at that if you haven't already done so. But essentially, what we do now is we first test for HPV. And so we do a smear test. We see if they are HPV positive. So that's what human papillomavirus positive. And that's often associated with cervical cancer. And if they are HPV positive, we'll send them over for a cytological examination. And so what that is that it's essentially looking at the cells in more detail to see if there's anything abnormal or potentially cancerous. If the cytology is abnormal, you would then refer the person to a colposcopy. So that's essentially just looking at the cervix in more closer detail. However, if, for example, you are found to be HPV positive, you get sent over to cytology and your cytology turns out to be normal, then you have to come back and test for HPV again in 12 months' time, so in a year's time. If after a year you are HPV negative, that's fine. You'll go back to doing the normal routine screening program every 3 years or every 5 years. However, if after that year you're still HPV positive, you'll then be sent again for cytology, your cells. And if that is still negative, then you would come back again in another 12 months' time to test for HPV. If at the 2-year mark, so after 24 months, you are still HB positive, then you will get sent for colposcopy. Now, I know that's a bit confusing. That may seem a bit confusing because there's a lot of steps to that. But essentially, it's HPV, your test. If that's positive, you'll go for cytology. If that is negative, you'll be retested again for HPV in a year's time. And then depending on that, you will either be sent to cytology again, or you'll be sent to having a HPV sampling again in another year's time. And regardless, if you're still HPV positive in 24 months, you'll go for a colposcopy. If you find, for example, you do someone's HPV test and you keep on getting an inadequate sample, you would repeat again in 3 months' time. And if you get 2 consecutive inadequate samples, you would refer them to colposcopy. Now, again, I know that is quite a bit, but you can listen back to the recording as well afterwards. But I would really recommend looking at PassMed. They have a really nice breakdown of how the HPV screening program goes. Another side note is that individuals who've previously been tested or have in the past have had sort of cervical cancer, not cervical cancer, but have been seen to have pre-malignant stages of cervical cancer, then after they get treated, they need to be retested again for HPV in 6 months' time, to see essentially if they've been cured. So that's your cervical screening program. You then have your breast screening program, so it's your mammogram. So that happens every 3 years for those between 50 to 70 years old, and there's like a trial going on where they're trying to extend the age range to 47 to 73-year-olds in different parts of the UK. But people who are increased risk of breast cancer, they can be eligible for screening actually before 50 years old, so at a younger age, if they've got certain risk factors, like they've got a strong family history of breast cancer. The last screening program I wanted to mention was your colorectal screening program. And so that involves doing a FIT test, which is basically looking at to see if there's any traces of blood in a stool sample that could potentially indicate bowel cancer. And you do that for every 2 years for those between 60 and 74 in England, and for those between 50 to 74 in Scotland. Something to mention though is that actually since last year, since April 2021, they've actually trying to extend the age range of the colorectal screening program to include those between 50 to 59 as well. So essentially be between 50 to 74, and they're trying to extend that gradually over the next 4 years. So that age range is also slowly starting to change in terms of the screening program for the people who are eligible for it. I hope that makes sense. Now, something that I wanted to mention was the kind of flow of assessment that someone would go through, particularly if they are having a workup for potential cancer. Because there's a lot of different steps that can happen and there are a lot of different stages. So what would happen, say, for example, it may initially come from a general clinical assessment, say, for example, in a GP setting, and they have some red flag symptoms like they've got weight loss, fever, and night sweats, or something may have been picked up in a screening program that I've just mentioned. And from there, you would do your bloods, and you would do sort of your standard bloods, like your full blood count, looking at your renal profile, looking at your electrolytes, things like that. And you might also then, you will more likely also include tumor markers, and that's something I'm going to discuss shortly as well, looking at specific tumor markers that is suggestive of different types of cancers and different tumor cancers that are associated with different types of cancers. And then, of course, you would want to send them for imaging, say, for example, a chest X-ray or certain CT scans. And then from that, once you do all of that initial assessment and, okay, you've got, okay, this person has a cancer, then you need to think about staging. And this is assuming that someone will be going for some kind of treatment potentially. But then you might want to be thinking about staging. So things like doing through a biopsy, either radiological staging or surgical staging. Again, I'm going to discuss that in a few moments' time. And then you've got your different types of treatment. So you can either go down a line of curative treatment where you're expecting actually this cancer could potentially be cured. And that's usually through a surgical intervention, particularly if you're talking about solid cancers. Or you might decide this is more appropriate to have a palliative treatment instead. And then, you might want to think about things like neoadjuvant treatment, which is a type of therapy that you do before someone has surgery or radiation in order to reduce the size of the tumor. And that can be helpful in terms of prognostic benefits and symptomatic benefits as well. Or you could do adjuvant therapy, where after someone has a tumor removed, either through surgery or radiation, you can undergo different forms of therapy to further address any potential micrometastases that may have come out from the primary tumor. So those are different forms and different branches of treatments that you can do. The key thing is you need to make sure that they're properly followed up and there's adequate surveillance, and that can be ongoing for multiple years. And every step of the way, especially particularly for cancers, is that there is an MDT, so multidisciplinary team approach taken, where you are having discussions with multiple different departments and different specialties, thinking about what the best plan and approach is for that individual and for their particular circumstances. So that's sort of just a generic flow of assessment that you might come across or you might see with people who are being worked up for cancer treatment or for cancer in general. The next generic principle I want to talk about was something called staging. So you probably all are quite familiar with what staging is, but essentially it's how our staging and how we stage cancers are based on our knowledge of how that cancer develops and what kind of treatments we have available as well, or the best types of treatments to treat that cancer. And the types of investigations that we use for staging has developed and varied over the years as well. And there are different forms of staging. So you might want to, so there's a clinical staging where it's more based on your clinical assessment, where you may think the stage of the cancer is based on the type of symptoms that they're presenting with. You have radiological staging where you're looking at your imaging, and based on that, you're deciding how far the cancer is spread. Of course, you have your surgical staging, so you're sort of actually taking a piece of the tumor or whatnot, and then you are looking at it through you're looking at it in the path lab, so doing a pathological staging as well, and seeing there more precisely how much the cancer has developed and how far it has spread. Now, a staging that you might be familiar with is something called the TNM staging. And again, it's a staging that tells us how far the cancer is spread. The staging is specific for the different cancers. But in general, the T stands for tumor, and I've put on the side here what T1 to T4 stands for. And essentially, it's going through how far the tumor has invaded into the tissue. So T1 invades in the submucosa, so that's still quite peripheral. And then as you go further down, essentially invades more into the neighboring structures. And so T4 is the last stage in the tumor size and invasion. Then you have N, which includes how many lymph nodes are involved, and that again gives you a good idea of the spread of the cancer. And N as well talks about if there's any distant metastases and involvement of distant organs as well. Again, the TNM staging, so what you see here is more generic, and it is, as I mentioned, specific to different cancers, but the general principles apply to all the different cancers, basically, who use TNM staging. Now, I should mention this TNM staging can also be converted to, as I mentioned, it's specific for specific cancers. So, for example, colorectal cancer, they use something called Duke staging, and that is based off the TNM staging, where Duke A, which suggests that the tumor has not invaded the muscularis propria, so it's remained in the submucosa. That Duke A counts as being T1 for colorectal cancer. So that's what I mean by the TNM staging can be specific to different cancers, but the general principles apply. And again, your particularly hematological cancers like your lymphomas have other more specific types of staging, like Ann Arbor stagings, which are more unique. And I'll let you guys watch the heme lecture on that to understand more a bit about what the Ann Arbor staging is. But it's just to mention that different cancers have more specific types of staging. But as I said, they can all kind of be generalized on the TNM staging or based on that. Another form of staging is something called grading, and what grading does, it looks at more of how the cells look like under the microscope, and you'll see in different forms of cancer the most The one that you may be more familiar with is in the Gleason score for prostate cancer. And so that's essentially looking at how well differentiated the cells are. So rather than looking at how far the cancer has spread, it's looking at how well differentiated the cells are, which in of itself can give you a good idea of how far down the line you are with that cancer, if that makes sense. And so the higher the grading you have, the more poorly differentiated the cancer cells are, which would suggest that you are in a higher grade, meaning you are sort of further down the cancer staging, and you've got a poorer prognosis, basically. I hope that makes sense so far. In terms of the principles as well of general cancer management. So like I said, you guys really don't need to know about specific details of cancer management because it's way too specialized and advanced. But what you do need to know is the general principles, and I've already touched on some of these already. So as I mentioned, you have your curative approach and you have your palliative approach. Your palliative being more about improving quality of life and symptom control. And in between that as well, and more towards, I guess, the curative line, is you have adjuvant therapies where you more focus on trying to tackle any micrometastases that may come about from treatment of or removal of a cancer through surgery or through radiation. And you have your neoadjuvant, which you give before undergoing surgery or radiation in order to reduce the size of the tumor. Now, with adjuvant therapy, there's different forms. So you can do your chemotherapy, you can do your radiotherapy, you can do biologics. So you can do short or long-term forms of adjuvant therapy. The only issue is that actually sometimes overall it might not be that beneficial for symptoms. It can help in the survival rate, although that apparently the absolute survival benefit is actually quite small. And there's no real way of assessing the benefit. There's no biomarker or way of assessing the benefit of that adjuvant therapy, but it can be useful in improving your overall prognosis or survival rate. Neoadjuvant therapy, so that's the therapy that you do before having any form of surgery or radiation in order to reduce the size of the tumor. Now that can improve survival, particularly for things like esophageal and gastric cancers. It can make certain type of cancers become more operable. So if you've got a massive tumor and you reduce that tumor, then that can make it easier to undergo surgery for that tumor. Say, for example, with breast cancer, lung cancer, loads of different cancers. So it can make certain cancers operable, which will in of itself improve your survival potentially. It can also make certain cancers, I said as for aesthetic reasons. So for example, with breast cancer, instead of doing a mastectomy, you could potentially end up doing a lumpectomy, so removing a smaller amount of the breast tissue with using neoadjuvant therapy because you've reduced the tumor size. So in that way, it can be more pleasing for the individual from an aesthetic perspective. And it also allows you to assess the biology of the tumor and the chemosensitivity if you're not sure if surgery is the most appropriate approach for treating that tumor or cancer, because you're essentially you're allowing yourself more time for deciding whether you should do surgery or not by doing this kind of pre-treatment. Now, before you decide whether you want to go down a curative approach or palliative approach, whether you want to do adjuvant or neoadjuvant therapy, the number one thing that you need to look at as clinicians, and again, this will be something discussed thoroughly in MDT meetings, particularly in oncology, is something called performance status. And performance status essentially is a guide that we use to help us decide what form of treatment is best for that patient. And as you can see, there are different levels going from 0 to 4, 0 being they're fully active without any restriction, of 4 essentially meaning that they're bedbound. So they're very, very frail. And yeah, they're bedbound. And so what we say with this is that in general, if you're, for example, at 0 or 1, you're at 0 or 1 performance status, then we tend to say that these individuals, they can tolerate therapies or surgery, because there's only some minor restriction in physical activity, but in general, they, they're ambulatory and they can walk around. Now, for those who are in status 2 or 4, so there's a lot more limitations to their activities of daily living, or they're completely bedbound, then we say that they potentially may not be able to tolerate as much of the side effects that are associated with certain types of chemotherapies and surgeries and radiotherapy. And so we might think twice before deciding, say, if someone is appropriate for a curative approach, if they have that level of performance status. However, this is all very much dependent on the individual. It's very context specific. And you also need to think whether their performance status is because of the cancer or whether it's non-cancer related. And that may also change your opinion on the treatment approach. But this is all very much based on the individual. And actually, with certain cancers, so for example, in small cell lung cancers, patients will often present already with a performance status of 3 and 4. So they're already very frail and sometimes bedbound, but they still might be given chemotherapy. So again, it's dependent on the individual, it's dependent on the context, and it's also dependent on the cancer. But it's still a very useful marker to help us give us a general idea of what our actual aim is behind whatever treatment approach we give to that patient. And you will see performance status being talked about a lot in oncology, and you may have seen it already on the wards if you're on there, if you've seen it. Now, in terms of the different forms of treatment, you have, I'm sure you've heard of some of these before. So you can categorize it into local or systemic forms of treatment. So you obviously have your radiotherapy, and the most popular being external beam therapy. And radiotherapy can be used for curative as well as for palliative purposes. And of course, you have surgery, and they tend to be, of course, more localized into the particular area where the cancer is. And things that work more systemically in principle are things like chemotherapy. And the idea behind chemotherapy is that it will target cancer cells that proliferate faster than normal. And so that's the general principle or idea behind chemotherapy. And you often see chemotherapy used simultaneously with radiotherapy too. You also have immunotherapy, and you have biologics and more targeted approaches, and they've really changed the game when it comes to cancer treatment and when it comes to survival of cancers. So for example, tamoxifen, using that in breast cancer. You have your rituximab, which you use in non-Hodgkin's lymphoma. And you have your imatinibs, which are used in acute lymphoblastic leukemia, and some of these are based as well on whether you have particular genes and different markers in your bloods. I'm not going to go into specifics of that, but these are very targeted approaches that have really changed the game when it comes to cancer treatment. Now, of course, with any of these managements, you've got serious side effects that you need to some of them you do need to be aware of, and of course patients will need to be cancelled on it properly before undergoing these treatments, whether it's for curative or palliative purposes. So for chemotherapy, I'm sure you all know, some of these side effects already, things like nausea and vomiting and alopecia that you get. You also get GI toxicity, so you might get inflammation of your bowels, and you might of your colon, sorry, or your mucosal sites, and you will often get diarrhea as a consequence of that. And the thing is with chemotherapy, and I'm going to discuss this in the next slide, is that there are certain agents that have quite specific side effects that you might be tested on as well. And I will go through that in a bit. Now, radiotherapy, again, there are lots of different side effects, some that you might see in the more acute phase, so things like being really tired, having skin changes and hair loss, and things that you might see later down the line with prolonged use of radiotherapy, things like contractures, so that's tightening of your muscles and tendons. And there's also a risk of actually having secondary malignancy in areas where you've had radiotherapy. Which is quite a sad side effect to have, but that is one to cancel people on. And the thing that I was always taught in med school with radiotherapy is that you tend to get what's known as fibrosis type side effects. So, for example, if you're having radiotherapy in your head and neck, you will often have problems with dysphagia, so difficulty in swallowing or painful swallowing. You'll have a decrease in your saliva production. If you're having radiotherapy in your chest, you will have issues with cough and shortness of breath. If you're having radiotherapy around your abdomen or your pelvis area, you might have issues around your bladder and your bowel, and you might get there's a potential for infertility and sexual dysfunction as well. So it can have these quite significant side effects depending on where you have the radiotherapy. And of course, immunotherapy as well, so your biologics and things like that, they often have side effects that are related to more autoimmune type symptoms. So the phrase that's used is itis, so inflammation essentially, so colitis, inflammation of your colon, and that can often cause severe diarrhea. You might get hepatitis, thyroiditis. You will often get skin rashes. And so particularly with immunotherapies, you really need to make sure you're monitoring their bloods, and often you will give them steroids if they are having these side effects, because what the steroids will do is that it will reduce the inflammation and try to basically calm the immune system down. Now, in terms of the specific side effects associated with some of the chemotherapies, I don't know if you guys have ever seen this chemo bear. That was a diagram I used to memorize some of the side effects I had to know for specific chemotherapies. But essentially, doxorubicin that you see here is associated with cardiac toxicity, in particular cardiomyopathy. Your cisplatin is associated with ototoxicity and nephrotoxicity, and is also associated with deafness. And you should be aware that with cisplatin, you can get hypomagnesemia, so low magnesium, and that can precipitate seizures. Your cyclophosphamide can cause hemorrhagic cystitis, and it can also cause bladder cancer, basically transitional cell carcinoma bladder cancer specifically. I've seen that come up in past med. Vincristine as well, I don't think you can see it here, can cause, vincristine is a type of chemotherapy drug that's often associated with neuropathy as a side effect. And bleomycin, another type of chemotherapy, is most associated with pulmonary fibrosis. This is a diagram that you might find useful to remember some of those specific side effects, but it is important to know those ones in particular. Now, I mentioned tumor markers briefly as a way that one of the earlier investigations that we might do when assessing someone for a potential cancer, because there are certain tumor markers that are associated with certain cancers. And again, we might use it in our initial assessment when we're investigating whether someone has a cancer. And sometimes we will use it. We will use tumor markers to monitor someone's response to a treatment. So, for example, CEA, which is a tumor marker used in colon cancer, isn't really used for diagnostic purposes, but it is often used to monitor response to treatment. So that's quite useful. CA125, again, is a tumor marker that, dependent on the level, may change your treatment approach to someone with ovarian cancer, depending on how high their CA125 levels are in their blood. These are some of the main ones that you do need to know. I mean, again, it depends on your med school, but I needed to know these tumor markers in my med school. And again, they are useful to have in the back of your mind what tumor markers are associated with what cancers. In general, though, when you're assessing someone's response to cancer treatment, first and foremost, like with anything, you need to look and listen to the patient. Do they look better? Do they feel better? Do they say that they're feeling better? That will give you, one of the more reliable, well, not necessarily reliable, but that will, that's one of the main things you need to look at to see if someone is improving or responding to their treatment is the patient themselves, obviously. Again, you can look at blood results, looking at certain blood markers, like the tumor markers and different blood test results. And the more reliable way of seeing someone's response is, of course, through imaging. And you will often do repeats, say chest x-rays or CT scans after 6 to 8 weeks or after 2 to 6 cycles of a treatment, unless they're clinically deteriorating. Okay, so that was just a run through of some of the key principles that you may come across in oncology. Now let's get started on SBA so I can stop talking for a bit. I'll read through the questions and I'll give you guys a bit of time to go through and to answer. So SBA1 is a 90-year-old man with a background of COPD, heart failure and dementia who presents with vague abdominal pain. An abdominal ultrasound identifies multiple hypoechoic liver lesions consistent with liver metastases. He is currently bedbound with QDS, so that's 4 times a day, package of care. Which of the following is an appropriate reason to not investigate the cancer further? So I'm going to give you guys about 30 seconds to answer this one. The poll is open. Okay, so most of you guys said 2, but the answer is yes, 2. The results of any investigation are not likely to affect treatment decisions. So going through that, number 1, he does not have capacity to consent to further investigation or treatment. So just having dementia doesn't mean that they don't have capacity. When testing capacity, it's time and context specific as well. So it's dependent in that situation at that time, do they have capacity? It's not just because someone has dementia doesn't mean that they do not have capacity. So that's not right. He has a DNA CPR in place. There's nothing actually mentioned about that. And even then, that's still not necessarily a reason not to investigate. His presenting complaint was not related to cancer. So if someone has got if someone presents with sort of red flag symptoms of or you are suspicious of cancer, you would still want to do certain investigations, because if they die of that cancer, you would want to know why you have died, basically. So you shouldn't not investigate at all. You still want to do something to investigate potential cancer, but it's more about how far you go in those investigations, how invasive you go in those investigations, and therefore, as a consequence, what you do in regards to treatment. His CKD precludes any investigation requiring IV contrast. So chronic kidney disease, dependent on what his EGFR levels are and how bad they are. And even then, if, say, for example, it's very low and you couldn't do contrast, or you think you couldn't do contrast because it would be contraindicated with someone who's got really bad kidneys, that's still a discussion that you would have with radiology to see whether there are alternative routes or ways out of that situation, basically, and potentially any other images that you could do, or whether you even need to do contrast with it. But that in of itself, again, wouldn't stop someone from having imaging done or investigations. But yes, the result is the main reason why is because having further investigations wouldn't affect his treatment decisions. And so what that is based on is the NICE guidelines on management of carcinomas with unknown primaries. Now, this is actually from NICE itself, and they have got, if you just Google NICE guidelines, carcinoma of unknown primary, they have a really nice step-by-step process of what the sort of steps are. So people who present with cancers, they will often present in an emergency situation, whether that be with bowel obstruction or a certain type of superior vena cava obstruction, which is something I'm going to discuss in a bit. They will often present in an emergency situation. And what the investigations you do is, of course, going to be guided by the history that you take and the examination that you do. And the examinations that you might do, you might want to do essentially a thorough examination of their body and looking at the different lymph nodes. So you might want to do a breast exam, looking at the skin properly. You might potentially consider doing like PR rectal or pelvis examinations and things like that. You could do thorough examination. And then from there, you want to do your blood. So you've got your routine things like your full blood counts, your renal profile, which is your U's, looking at calcium levels. And you might want to do also specific cancer tumor markers as well. And that might be in your first initial step. Nice guidelines as well, so just doing a urine analysis. Particularly for elderly patients, you might want to do a myeloma screen. So say, what's the thing that they say? If you've got anemia, if you've got an AKI, and someone has back pain, and particularly if they're elderly, you would want to rule out myeloma as well. And you also want to do that for looking if there's any bone lesions. And imaging wise, chest x-ray. Anyone who comes into A&E, and if you're potentially thinking about admitting them, by just general procedure, they should have a chest x-ray. And then further down the line, you might want to do a CT, chest, abdomen, and pelvis. And what that will do is basically like a whole body CT to see where the cancer could be coming from, or if there's any mets as well. And of course, you can do your biopsy and cytology independent on that, further investigations and things that are more specific or niche. And according to NICE, you should investigate if the results will affect the treatment, if the patient understands why they're being investigated, if they understand the benefits of investigation and treatment, and they're prepared to accept some forms of treatment. You don't necessarily need to investigate if the above criteria aren't met, or if they're unfit for treatment. Now, this is according to NICE guidelines, but really when it comes to practical, in the practical sense, you would still investigate someone. Like, you would still do a chest x-ray, and you would probably do a CT cap, even if they're 90 and bedbound, just to figure out what cancer they have and if there are any mets, because you would want to know what is going on. But you just wouldn't necessarily do any sort of curative treatment or anything sort of intensive like chemotherapy. You could still do radiotherapy, as I mentioned, for palliation. So I know that's what the NICE guidelines says, but actually when it comes to real life, it's not necessary, it doesn't necessarily go like that. But for your exams, you need to know the NICE guidelines. I hope that makes sense, guys, and please do let me know if you need me to slow down. SBA 2. A 80-year-old man has come into A&E complaining of severe abdominal pain starting a few hours ago and now vomiting. He has a 3-month history of change in bowel habits and weight loss, which he cannot quantify. On examination, he is extremely tender to light palpation of his abdomen, and there are tinkling bowel sounds on auscultation. Considering the most likely diagnosis, what is the most diagnostic investigation? So I'll give you guys some time to answer that question. So most of you guys put, I think, colonoscopy, which I can understand. I think, yeah, we'll split between colonoscopy and CT abdomen. So the answer is actually CT abdomen for the diagnostic purposes. So when someone comes in, so firstly, what's going on here? They are having bowel obstruction, so malignant bowel obstruction. And you know that because number one, he's got this history of changes in bowel habits and weight loss, and he's 80. So those are some of the red flags associated with colon cancer. So you know he's got cancer. He then talks about having severe abdominal pain and which is very, very tender. And he's got these tinkling bowel sounds. And tinkling bowel sounds you hear in obstruction because of tension of the air or the fluid in your dilated bowel loops. So that's why you get this tinkling bowel sounds on auscultation. Now, in terms of what is diagnostic, so actually your CT abdomen is the thing that will diagnose whether you have bowel obstruction or not, because it will localize where that obstruction is and potentially identify the underlying pathologies. Your colonoscopy isn't going to diagnose bowel obstruction, but it may be used for treatment. But you also wouldn't do colonoscopy in an acute bowel obstruction because there's a risk of perforation too. So you need to be careful before jumping into doing things like that. An abdominal X-ray, when you do abdominal X-rays, again, it won't. If someone's got a bowel obstruction, the abdominal X-ray will just show like really loads of dilated bowel loops that might make you think, oh damn, this is a bowel obstruction. I need to order a CT abdomen. What you might also see in abdominal X-ray, something called Wriggler's sign, which is suggestive of perforation. In which case they would have sort of a rigid abdomen and they would be very peritonitic on examination. But again, abdominal X-ray would not diagnose your CT abdomen. So what is actually diagnostic is CT abdomen in bowel obstruction. Now, bowel obstruction is most likely to occur in the large bowels. It's often associated with colorectal and gynecological malignancies. And again, what you get is you get an absence of stool or flatus. And it's really important when you're taking history from these patients, not just to ask them about whether they've passed any stools, but also if they've passed any gas. Because if they haven't passed both of them, then you're very worried about that. And of course, abdominal pain and nausea and vomiting. Investigations, so you want to do your bloods. You want to particularly do a VBG for lactate. And that's something that, particularly if talking to surgeons and things like that, they want to look at the lactate level because it's a sign of ischemia potentially. And you want to do a group and say for these patients in case you need to give them blood transfusions. In general, just do group and saves in people when they come into ED. It's quite a useful thing to have. An abdominal X-ray is usually first line, but CT abdomen is the diagnostic. Now, management-wise, you would want to keep the patient nil by mouth. And it's quite surprising, but with obstruction, the first step is actually more supportive management. And what you do for that is you put an NG tube in them and you do this, what's called drip and suck. So it's a process of causing abdominal decompression, which can sometimes help relieve the bowel obstruction. And you obviously want to back them up with fluids and things like that. And if with supportive management, it's still not working and they've still got this bowel obstruction or they've perforated, then you need to do sort of surgical intervention to treat the underlying cause of the bowel obstruction and potentially to remove parts of the bowels that have already dead or have already died. I hope that makes sense. SBA 3. A 70-year-old male with a history of prostate cancer presents to A&E with severe back pain, which has been increasing in severity in the last couple of weeks and keeping him awake at night. On examination, it is clear that there is bilateral weakness in both of his legs with reduced sensation peripherally. He has had an episode of urinary incontinence in A&E. Considering the most likely diagnosis, what is the first best step in management? So I'll give you guys some time to answer the question. So I got quite a split response. I think you all chose a different answer to this. I've got a bit of 1, 2, and 5, but the actual answer is 3. So what is this SBA suggesting? What's the emergency here? So the emergency here is essentially spinal cord compression as a result of the cancer compressing onto their spinal cord. So they've got a history of prostate cancer, and this is something I'm going to discuss shortly, but prostate cancer often metastasizes to the bone. And that is causing them to have this very severe back pain alongside these neurological symptoms of bilateral weakness in their legs with reduced sensation and an episode of urinary incontinence. So that should scream out to you spinal cord compression. Now, the key to this SBA is that it's the first best step in management. And the first thing you want to do is make sure they don't move. And you want to make sure that they have total bed rest, because there's a high risk of them having a unstable spine and causing further damage. So you want to make sure, first and foremost, that they stay on their bed. Then you can give them the steroids, and steroids is the main form of treatment for people with spinal cord compression. I know some of you guys chose morphine, which I can understand why, because you would think, okay, pain relief as being the first step, but in terms of what's most important is actually keeping them still. And MRI, yes, is definitely a key part of their management, or a key investigation that you have to do for anyone you're suspecting of cord compression, but it's not the first thing that you do. So with spinal cord compression, there are 5 cancers that are most commonly metastasized to the bone. And the way I remembered it was a phrase kettlebell, or lead kettle, sorry, not kettlebell, lead kettle, lead being PB and a kettle KTL. And those cancers are prostate, breast, kidney, thyroid, and lungs. And those are the 5 cancers that you need to remember as most commonly metastasizing to the bone. And where you often find sites of compression tend to be in the thoracic region. And so one of, it's particularly in a GP setting, a red flag symptom you need to be aware of people who have thoracic back pain, because musculoskeletal back pain tends to actually be lower down in the lumbar region. You don't really get thoracic pain. That is more indicative of potential cancers, actually. The next place is lumbar, and then after that, cervical. Again, back pain that you get, the symptoms that you get, you would obviously get back pain. It's often worse at night or when laying down because of raised intracranial pressure. And you will also get limb weakness because of compression onto certain nerves that cause these neurological symptoms. And you tend to get in spinal cord compression more upper motor neuron symptoms, so things like weak limb weakness. You may get increased tone and increased reflexes, actually, but realistically you get a little bit of both upper and lower neurological symptoms. And of course you can get bowel and bladder dysfunction. Investigation wise, you want to do a PR exam, because you want to look at essentially the anal tone as well. And that can also give you a good idea of sort of neurological damage that has been done. And you need to do a MRI scan within 24 hours. And actually, spinal cord compression and cauda equina are really one of the few indications of an acute, one of the few indications of why someone would need an acute MRI or need an MRI very, very quickly. Everything else can kind of wait when it comes to MRI images. And you need to make sure that they have flat bed rest until the MRI is done, and you can ascertain the stability or lack of stability of their spinal cord. Now, management wise, I've already mentioned the total bed rest to immobilize the spine. And you can do, if you need to look at their back or examine their back, you need to do a log roll, which is just a kind of maneuver that you can do of moving them in a way that is stable or wouldn't damage their spine further. Some of you guys already got this. The treatment is going to be steroids. You can do 60 milligrams, or and you can give that in different ways. And you need to remember, because you are giving high dose steroids to cover them with a PPI, because steroids is often associated with problems around sort of causing stomach ulcers or gastritis and things like that. So give them a PPI, it will make them feel better. And you need to discuss about how to manage their spinal cord compression longer term in an MDT situation. So the more definitive form of treatment for someone with spinal cord compression is surgery to deal with their metastases or their cancer in their spine. If, however, someone isn't suitable to have surgery, what you might want to do is instead give them radiotherapy, and that will just help. And that's more for a palliative approach. It can help in terms of for symptomatic reasons. So it will give them symptomatic relief of their bony mets, basically. So that's more of a palliative approach to management of spinal cord compression. SBA4, a 70-year-old woman has high-grade lymphoma and is undergoing inpatient chemo. Today, she had a seizure and cardiac arrhythmia as a complication of a chemotherapy treatment. Given her likely chemotherapy complication, what is the most likely laboratory finding? I'm going to give you guys about 30 seconds for this. It's a bit of a hard one. We should be done soon, guys. I'm sorry, I know I'm overrunning a bit. So, for the sake of time, so what the answer is this question. The answer to this question is actually one, low calcium. Now, I'll be honest with you. With this SBA, you will either know it or you won't. So, what this SBA is suggesting. What is this SBA suggesting is someone who is having what's known as tumor lysis syndrome. Now, so you've got this 70-year-old who's got this lymphoma and is undergoing chemotherapy. They then have a seizure and they've got this arrhythmia as a complication of her chemo treatment. Now, tumor lysis syndrome is what that syndrome is essentially related to rapid cell death, and it's most often related to those who have just started chemotherapy, particularly for your hematological malignancies, things like your leukemias and your lymphomas, because what's often associated with these cancers is high proliferation of cells. And that is further exacerbated sometimes with chemotherapy. And so that just causes this whole like wildness in your body that causes your cells to break down, and as a consequence resulting in tumor lysis syndrome. So it's a rapid proliferation of cell death. And with tumor lysis syndrome, what you get in your blood is you get high potassium, high phosphate, you get decreased calcium, and increase in uric acid. Now, why that happens? I'll be honest with you, I don't know specifically, but from my understanding, the way that is when your cells break down, all the stuff that's in your cells come out. So your potassium will come out, your phosphate will come out. And I believe the calcium that is in your blood ends up binding to some of the potassium or the phosphate. And as a result, your calcium goes down. And I'll be honest with you, I don't know why your uric acid goes up, but that's the blood results that you get in tumor lysis syndrome, which is why the answer to the previous SBA was low calcium. Your magnesium isn't usually affected. Now, in terms of the management for tumor lysis syndrome, so people who are often having chemotherapy with hematological malignancies in particular, they will often be given something called rasburicase as a kind of prophylactic medication. And what that will do is it will help in terms of reducing the levels of uric acid in your blood, or some of these people might be put on allopurinol. And allopurinol doesn't remove uric acid from the blood, but it can prevent its formation. And so sometimes you might see people on that prophylactically. And in tumor lysis syndrome, because you kind of get this electrolyte imbalance with this high potassium and high phosphate and decreased calcium, you will get these complications like arrhythmias, which as a result could precipitate seizures, or these electrolyte imbalances in of itself can precipitate seizures. And so that's what the typical image that you get with tumor lysis syndrome. I hope that makes sense, guys. Next SBA, a 55-year-old female has presented, we're nearly done. A 55-year-old female has presented to A&E severely unwell. She has recently undergone chemotherapy for acute myeloid leukemia a few weeks ago, but has been fine until recently, where she has been spiking fevers of 39 degrees. Considering the most likely diagnosis, what is the most appropriate first step in management? Give you guys about 30 seconds to answer that question. Okay, guys, for the sake of time, I'm just going to go through. So the answer to this question is 3, starting tazocin, which is an antibiotic. So most of you guys got this question right, so well done. So what this is neutropenic sepsis. So it's an individual who's got cancer, recently been treated with chemotherapy, and she comes in spiking of fevers. So this is neutropenic sepsis. Now, neutropenic sepsis, in terms of its exact definition, is defined as having a neutrophils of less than 1 times by 10 to the power of 9, and having either temperature, signs or symptoms suggestive of an infection, and raised CRP, which is a type of inflammatory marker. Now, with neutropenic sepsis, like with any forms of sepsis, you want to undergo your sepsis 6 protocol. So taking your blood cultures, taking your bloods, taking a VBG, particularly looking at lactate, because you want to see potential, because lactate is, as I mentioned, a marker of ischemia, and it's also very useful in the setting of sepsis as well. You might want to do a urine culture as well, sputum samples if they're producing sputum, stool samples, just to see where the infection could be coming from. And then, of course, you need to give them antibiotics, and you need to give that within 1 hour. And really, with any forms of sepsis, not just with neutropenic sepsis, it's nice if you can do blood cultures before you do antibiotics, but don't delay giving people antibiotics for a long time just because blood cultures haven't been done, because you really do need to give them antibiotics. And don't wait for their results to come back, particularly if you know, clinically you're suspecting they've got an infection. If they're penicillin allergic, you give them ciprofloxacin. Of course, like with any of the sepsis 6 protocol, you want to make sure they've got fluid, and you want to monitor their urine input and output. And some people actually, they can be given ciprofloxacin as prophylaxis to prevent neutropenic sepsis. And some people are given something called GCSF, which means granulocyte colony stimulating factor. And what that does, it basically stimulates your bone marrow to produce neutrophils. So that can sometimes be given to some people prophylactically to prevent them from having neutropenic sepsis. I hope that makes sense. Next SBA, a 70-year-old male has noticed that in the last couple of days, every time he goes to raise his arms above his head, he becomes severely swollen and red in the face. On top of this, he has had a few months' history of coughing and becoming increasingly short of breath. Considering the most likely diagnosis, what would be the best management? Okay, just opened up the poll. Okay, so sorry guys, I'm going a bit more faster this time, but you guys were quite split with this. So most of you guys chose 3 and some of you guys chose 5. The actual answer is dexamethasone, 8 milligrams. So what this SBA is showing is someone who's got superior vena cava obstruction. So they've got this they've got this history of coughing and becoming short of breath. They've got this symptom where they raise their arms above their head and their face becomes swollen and red. And what that symptom is suggesting of is something called Pemberton sign. Pemberton sign, yeah, that's the one, where basically you get swelling of your face and neck because of compression to your superior vena cava. And you often see this with lung cancers, because you can imagine you've got cancer in your lung that's going to press on your superior vena cava. And the management for superior vena cava obstruction is with steroids. So, okay, so firstly, you get this compression of your superior vena cava. It's most associated with non-small cell lung cancers. Also can be associated with lymphomas and your metastases, and also germ cell tumors, things like teratomas, because it can cause mediastinal enlargement. You can imagine with this obstruction, you will get shortness of breath. You might get orthopnea, where you find it difficult to lie flat on your bed. You might get stridor and this swelling of your face and neck when you raise your arm, also known as Pemberton sign. And you can see that here in this image, as an image showing Pemberton sign. Someone's raised their arm and their face goes really red. Investigations, of course, you're going to do a chest x-ray, and you can do a CT scan to give a more detailed imaging of what's going on and where's pressing on what. And Doppler as well, apparently, you can use to figure out the severity of the obstruction. Now, what do you want to do with these people? You want to get them to sit up to relieve pressure on their superior vena cava. The first thing that you actually want to do is give them steroids. Now, I know you guys, some of you guys chose IV hydrocortisone. To be honest with you, actually, when it comes to IV and oral steroids, the impact is actually the same. Giving someone steroids IV is really no different to giving someone oral steroids. The only reason we give people IV steroids is because the equivalent version orally would be at a very high dose. And so that's the only reason why we sometimes give IV, because, okay, hydrocortisone can be stronger, is stronger than, for example, prednisolone, but the efficacy of IV, like the IV route versus the oral route, is actually the same. And you give dexamethasone specifically in superior vena cava obstruction. And actually, with a lot of these oncology cancers, they prefer dexamethasone. Stent, which is someone actually chose as well for the previous SBA, you do that more for palliation if they've got really severe vena cava obstruction and you need a more long-term management. But what you do need to do is make sure that if they're going to do not stent them before you give them any systemic treatment, because the stent might just slip basically if the tumor shrinks. And of course, the mainstay treatment will be treating the cancer itself, either through chemotherapy or radiotherapy, or even surgery if they are for that type of intervention. So the main thing is, in an emergency situation, you would give them steroids. And for long-term, for curative, it's treating the cancer, or you could do stents for palliation. 2 more SBAs, guys. So a 47-year-old gentleman comes into the GP surgery for test results following a 3-week history of feeling tired. His full blood results are as follows. Which of the following is the single most appropriate management plan in this patient? I'll give you guys a bit of time to answer this question. This one's a little bit hard if you don't know the guidelines specifically. Okay, so just to go through it. So most of you guys have given the answer 5. The actual answer is 2, an urgent chest x-ray. Now, this is a really cheeky one because basically, this is if you either know the referral guidelines or you don't. So this gentleman comes in with a 3-week history of feeling really tired. His bloods, the only thing that is different is his platelets, which are slightly raised. So he's got a little bit of thrombocytosis. Now, the specific guidelines for when to refer someone for an urgent 2-week wait referral in lung cancer, for not a 2-week wait referral, sorry, an urgent chest X-ray under the 2-week guideline or referral for query cancers, is someone who is over 40 and has either recurrent chest infections, finger clubbing, lymphadenopathies, either in the supraclavicular or cervical region, chest signs consistent with lung cancer, or thrombocytosis. So having one of these warrants having an urgent chest X-ray within 2 weeks to rule out lung cancers or mesothelioma. So going back to the SBA, that's why number 2 was correct. That's why he warranted having an urgent chest X-ray. 1 is wrong because he does have abnormal blood because he's got this thrombocytosis. C is wrong. So number 3, sorry, is wrong because I understand like practically it's only raised very like in a very small amount. It seems really minor, but actually if you're being strict in terms of what the guideline says, he technically does warrant an urgent chest X-ray. Bone marrow biopsy is a wild step to take. And hematological referral, I understand why you might be thinking that. However, for heme referral, you would get more what was known as B-like symptoms, which are symptoms associated more with hematological cancers, things like lymphadenopathy, organomegaly, generic things as well, like weight loss, fevers, night sweats. And you guys should attend the hematological lecture as well, and you'll learn more about what these B symptoms mean specifically. But for this SBA, the answer is actually 2. Now, other referral guidelines that you need to know. So for lung cancer, you also can do a 2-week wait referral to a lung cancer clinic for people with chest X-ray signs of lung cancer or people over the age of 40 with unexplained hemoptysis. That warrants a 2-week wait referral to a lung cancer clinic. And I've already mentioned the 2-week wait referral to have an urgent chest X-ray. Other referral guidelines you need to know of is things like your colorectal guidelines. So you can refer someone on the 2-week wait pathway for query colorectal cancers if they're over 40 with unexplained weight loss, abdominal pain, or if they're 50 with unexplained rectal bleeding, or if they're over 60 with iron deficiency anemia and changes in their bowel habit. There's breast cancer referral guidelines. I'm not going to go through all of this now for the sake of time, but if you guys fill in the feedback at the end, you'll get these slides. But those are the breast cancer referral guidelines. These are all based on NICE guidelines. These are the referral guidelines that you see with ovarian cancer. Interestingly, for ovarian cancer, the only urgent referral is ascites or pelvic abdominal mass, of which you need to exclude things like fibroids. But actually, in urgent investigations, what you do want to look at is their tumor marker CA125, particularly if they have some of these generic symptoms, and especially if they're 50 or over. So that's quite different with ovarian cancer, actually. Skin cancer, I actually did a talk on dermatology a few weeks back. You can see that on YouTube. But these are some of the specific referral, and I go over in my dermatology teaching about some of the more specific referral guidelines for skin cancer, but I've just listed them out here. You guys can look at this in your own time. And yeah, those are there are more referral guidelines for other types of cancers that I'm not going through all now, but those are some of the key ones that you do need to know of, particularly in SBAs and ostomy situations. And you need to be aware of some of those red flag symptoms and when to refer under 2-week wait. Okay, last SBA, a 70-year-old gentleman presents to A&E with a 7-week history of progressive weight loss, shortness of breath, and hemoptysis. His chest X-ray is shown. Given the most likely diagnosis, which of the following cancers is the most likely primary? So this is those ones, again, that you either know or you don't. Okay, for the sake of time, I'm just going to go through it. The answer to this question is renal cell cancer. You guys all got this right. So, what you see here on this image is known as cannonball Met. So this chest X-ray shows a bunch of fluffiness across the whole, across both lungs, and the typical way that they describe this chest X-ray is with cannonball Mets. And the two most common cancers associated with this is renal cell carcinoma and choriocarcinoma. Now, renal cell carcinomas, the typical triad that you get in sort of past med would be like flank pain, hematuria, and abdominal mass. But actually, in real life, that's actually rarely present. It's only present in like 5 or 10% of cases do they present with this typical triad of flank pain, hematuria, and an abdominal mass. But what I can say with it is that it's very associated with cannibal Mets. Choriocarcinoma, there's no reason why you would think it would be that. There's no suggestive of any placenta or any testicular pathology. And you also tend to get choriocarcinomas, particularly in something called molar pregnancies, which is a type of complication that you can get in pregnancies. If someone has that, they would be pregnant, and they would also typically get a hyperemesis, so they would get a lot of vomiting during their pregnancy, which is suggestive of choriocarcinoma. Prostate endometrial cancer, okay, obviously they're going to be that in a man. Thyroid cancers aren't associated with cannibal Mets. And although this gentleman has a history of weight loss, shortness of breath, and hemoptysis, and he probably does have a lung cancer, it's actually they don't really cause cannibal metastases. The main ones are, as I mentioned, your renal cell carcinoma and choriocarcinoma. Other ones that you can get is also prostate cancers and other synovial carcinomas and endometrial carcinomas. But the most common ones, when you see cannibal Mets, think renal cell carcinomas and maybe a choriocarcinoma as well. Okay, that is it. That is the final SBA. I'm really sorry I had to rush, particularly towards the end there. If you have any questions, please email, or I'll do my best to answer those questions. But if you could please fill in the feedback form. You guys will get the slides once you fill in the form. And then you can go through some of those SBAs and those referral guidelines and things like that in your own time as well. But thank you guys for listening.
Thanks so much, Nazifa. The feedback stays open as well for people watching online. So please do fill it in, even if you're watching on YouTube, I mean. And thanks everyone for coming and for taking part in the polls as well.